Thank you for that kind introduction. I'm pleased to talk to you today about long-acting antiretroviral therapy prevention focused on long-acting injectable PrEP and review the current clinical evidence. As we have heard today, many clinical trials and emerging real-world data over the last decade has demonstrated that oral antiretroviral therapy as PrEP, can reduce HIV acquisition if taken as prescribed. Oral PrEP success relies on regular adherence to the oral tablets, particularly for women for whom there is less forgiveness in missed doses. Despite expanding access to oral PrEP, individuals at risk can experience significant barriers to daily pill taking, including stigma, judgment, and sometimes the threat of violence by family members, partners, or the community. Novel long-acting products like cabotegravir, administered less frequently, may simplify PrEP use and provide a discrete strategy for PrEP. Injectable PrEP has several advantages, in addition to being a preferred stated method by the populations who desire to use a PrEP product. Every 2 months injections can directly tackle adherence issues, and it is very discreet. But it can't be removed once injected, so there could be potential for prolonged side effects. Also, there is a long pharmacologic tail after the last injection, which may have resistance implications in the event that one becomes HIV infected. And more recently, current testing algorithms may not detect breakthrough infections as effectively, and Dr. Landowitz will be discussing that after me. The clinical data to date stems from 2 clinical trials that I will now review. HPTN 083 and 084 trials have recently reported their primary results. These companion studies have similar objectives, designs, but targeted different risk groups for HIV. The primary objective of both studies was to evaluate the relative efficacy and safety of cabotegravir injection versus oral TDF-FTC in preventing the sexual acquisition of HIV. It's important to note that both studies had active comparators. To characterize some of the similarities and differences of the study, I've included this side-by-side comparison. Both studies used injectable cabotegravir and oral TDF-FTC. HPTN 083 targeted and enrolled 4,570 cisgender and transgender women who have sex with men, while HPTN 084 targeted 3,224 cisgender women. HPTN 083 had sites across 4 continents, while HPTN 084 targeted only sub-Saharan African sites. HPTN 083 was out of the gate sooner in December 2016, and 084 started in November 2017. 083 had a non-inferior design, essentially to look at if they were the same, and HPTN 084 had a superiority design to see if cabotegravir injectable was better than TDF-FTC. Both studies targeted and enrolled groups deemed at highest risk for HIV infection based on local epidemiology. HPTN 083 included those who had any reported non-condom receptive anal intercourse, reported greater than 5 partners, stimulant drug use, incident rectal or urethral STI in the past 6 months, and in the United States, having a SexPro score less than or equal 16. This study purposely had targets to enroll 50% of its population under age 30, include greater than 10% transgender women, and 50% of the US enrollment should be Black. And notably, all of these targets were met by HPTN 083. In HPTN-084, sexually active women aged 18 plus at risk of HIV living in sub-Saharan Africa were enrolled. Countries involved included South Africa, Botswana, Eswatini, Zimbabwe, Malawi, Kenya, and Uganda. HPTN-084 used the modified voice risk score to identify participants likely to be at substantial risk for HIV and PrEP eligible in accordance with country and WHO guidelines. The score is based on a composite of characteristics related to age, partner characteristics, and alcohol use. The cutoff was increased from 3 to 5 in version 2 of the protocol in order to ensure the highest risk groups were enrolled. In both studies, participants were excluded if they had any medical or other contraindications to either study product, including hepatic or renal insufficiency. Also, if they had any history of seizures. This is the study design of HPTN-084. Participants were randomized 1-to-1 to one of the study arms. In the Truvada arm, participants received active Truvada and placebos for cabotegravir, and in the cabotegravir arm, participants received active cabotegravir and tenofovir FTC placebo. There was a 5-week oral lead-in period where oral tablets were taken to ensure tolerance of the product before injection. After the lead-in, participants received injections of cabotegravir or placebo, and they received a loading dose at 4 weeks and then injections every 8 weeks thereafter. Participants who discontinued injections for safety or other reasons were offered open label TDF-FTC for 48 weeks after discontinuation of study injections. This was to address the hypothetical risk of resistance in emergent infections that might occur during the pharmacokinetic tail. Pregnant women who were offered open label TDF-FTC throughout pregnancy and breastfeeding, and HIV and pregnancy testing were done at all of the visits where study products were administered. HPTN-083 had the same general design, including the step 1 oral lead-in phase, the step 2 injection phase, according to the same dosage and same frequency of injections, and then had the open label oral Truvada to cover the tail. How well did these products work? Both studies had the same data safety and monitoring board and underwent review at 6-monthly intervals. And notably, both studies were stopped early for demonstrated efficacy. In HPTN-083, a total of 52 infections were noted, 13 in the cabotegravir arm and 39 in the TDF-FTC arm. The incidence in the cabotegravir arm was 0.41 per 100 person years, and the rate in the TDF-FTC arm was 1.22. This corresponds to a hazard ratio of 0.34, representing a 66% reduction of HIV acquisition favoring cabotegravir. And this actually met the definition for superiority, even though the study was designed for non-inferiority. Here we see the cumulative incidence of HIV acquisition over time, highlighting again the 66% reduction of HIV acquisition in the cabotegravir arm. In HPTN-084, 40 confirmed HIV infections were noted. The overall HIV incidence among all study participants was 1%, suggesting that both products were highly effective in preventing HIV in this at-risk population. 4 infections were detected in the cabotegravir arm, which is equivalent to an incidence of 0.2%, and 36 infections were detected in participants assigned to the TDF-FTC arm, which is an incidence of 1.86%. In reviewing the cumulative incidence of HIV over time since enrollment, we see that women in the cabotegravir arm had an 89% lower risk of HIV infection compared to TDF-FTC. Most likely, this was due to an adherence advantage conferred by 8 weekly injections. In summary, both studies showed superiority of cabotegravir over daily oral TDF-FTC. Now let's discuss adherence. For both studies, a subset of participants receiving TDF-FTC had sampling to measure tenofovir levels to help understand oral adherence to the study product and how it might inform the efficacy results. This slide demonstrates the adherence levels to oral product in HPTN 083. In green colors are the proportion of patients that relate to 4 to 7 or 7 doses per week. We can consider this good adherence. The red highlights those with no detectable levels, and this would be non-adherence, and the yellow is in between. Overall, there was generally high adherence in this population, but over time, one sees the proportion that is green gradually decrease, while the portion in red and yellow increases somewhat, suggesting that adherence challenges increased over time. However, note this is quite high adherence for HPTN 083. In HPTN 084, a similar analysis was conducted. Overall, 62% of the participants receiving TDF-FTC had detectable concentrations of tenofovir, and 46% had levels consistent with daily use. Note this is somewhat lower than the HPTN 083 population. We see that initially at week 4, the levels were higher, and gradually over 1 year, we see that just over half have detectable levels, suggesting again that pill taking was particularly challenging for this population. Also, these levels likely demonstrate why the results are different for cabotegravir versus Truvada. Here we see the injection coverage for HPTN 084. This shows that essentially coverage was high and maintained above 90%, essentially for the entire period of the study, and emphasizing the adherence advantage that long-acting injections can provide. Let's now shift to safety. In HPTN 083, grade 2 or greater adverse events were generally balanced. Although highlighted here in the red boxes, we can see that decreased creatinine clearance was more common in the TDF-FTC arm, and nasopharyngitis, increased blood glucose, and pyrexia were more common in the cabotegravir arm. In HPTN 084, we actually see that adverse events at grade 2 plus or higher, there was actually no differences in the arms. For both studies, injection site reactions varied by arm, and more participants in the cabotegravir arm experienced this adverse effect. Here, for HPTN 083, we see that just over 80% of the participants reported injection site reactions in the cabotegravir arm, compared with 31.2% in the TDF-FTC arm. The proportion reporting injection site reactions did reduce over time with subsequent injections. And this study had 2.2% of cabotegravir participants permanently discontinue cabotegravir due to injection site reactions, and this correlated with the severity of the reaction. In contrast, in HPTN 084, a similar pattern held, that injection site reactions were more common in the cabotegravir arm, but the magnitude was dramatically less. 32% of participants in the cabotegravir arm reported any injection site reaction over time, compared to 9% in the TDF-FTC arm. This was highest at the initial visit and essentially became negligible over time. Most injection site reactions were mild and occurred within the first 1 to 2 days of injection. And for HPTN 084, there were no discontinuations due to this adverse effect. Weight gain has been an interesting area for exploration related to integrase inhibitors, tenofovir and TAF. So we evaluated weight change. Here we can see there is a small immediate weight increase in the cabotegravir arm, approximately 0.4 kgs. But then there is steady linear increase over time, such that when you evaluate at later time points, the amount of weight gain is actually similar over time. A similar trend is seen in HPTN 083, where an initial weight gain was noted in the cabotegravir arm through week 40, but then from week 40 to 105, the weight gains were similar, such that at the end of the evaluation, the weight gains are not significantly different. I also will report on HPTN 084 pregnancy issues. We observed 50 pregnancies during the study, and there was no significant difference by pregnancy incidence by arm. It was quite low. There was high adherence to the family planning requirements. Of the 50 confirmed pregnancies, 23 are ongoing, and we have outcome data for the remainder. There were 20 live births, 10 in each arm. There were 3 pregnancy losses at 20 to 36 weeks, including 2 cases of intrauterine fetal demise, 1 associated with pregnancy-induced hypertension, and there was also a miscarriage at 21 weeks. There were 4 pregnancy losses at less than 20 weeks, and 3 of these were elective terminations. There were no congenital anomalies observed. So in summary, both agents are highly effective in preventing HIV. In HPTN 084, the pooled incidence was essentially 1%. In 083, it was 0.81 per 100 person years. Cabotegravir was superior to daily oral TDF FTC in both studies. There was an 89% lower risk of HIV infection in 084 and 66% lower risk of HIV in 083. Cabotegravir long-acting, given by injection every 8 weeks, likely provided an adherence advantage over the daily oral TDF FTC based on the subset analysis of tenofovir levels. Both products were safe and well tolerated, with few differences in grade 2 or higher adverse events, with the exception of injection site reactions. Injection site reactions were generally mild, associated with pain, and generally occurred at the first injection. Injection site reactions were more commonly reported among men. Initial weight gain was noted for cabotegravir, but similar modest gains in both arms occurred over time, such that at 3 years, similar weight gains had occurred. Cabotegravir is the first safe and effective injectable PrEP agent for cisgender women, men who have sex with men, and transgender women. I'd like to acknowledge the study participants who volunteered their time to this effort. Both studies are supported by the Division of AIDS, the NIAID, and receive funding with ViiV, Bill and Melinda Gates, and generous contribution of study drug by Gilead Sciences. And we acknowledge the incredible teams behind this work that has been done by the 084 and 083 teams. Thank you very much.